Welcome, folks. In this video, we're going to be taking a philosophical first look at questions in debates about euthanasia. So we're going to be looking at our small little textbook for the term by Tony Hope and Michael Dunn, a very short introduction to medical ethics. This is a fascinating and often very controversial topic, the topic of euthanasia, sometimes referred to as assisted dying in medicine. And within this context, we're going to start to think about how we might approach this topic philosophically. So what we're going to do first, this is a valuable philosophical technique, is to compare our reactions to a pair of cases. So we're going to get two cases, and these are cases provided by Dunn and Hope. Here's our first case. A 92-year-old man with prostate cancer, whose life could be extended by several months, but no more, by an operation and chemotherapy, refuses these treatments and asks only to be kept comfortable and out of pain. His doctor respects his refusal of treatment, and the patient dies within a few days. So that's our first case. The second case we looked at in a previous video briefly. This is a case involving a woman named Lillian Boyes. So she was a 70-year-old patient with very severe rheumatoid arthritis, and her pain seemed to be beyond the reach of painkillers. And she was expected to die within a matter of days or weeks. She asked her doctor, Dr. Cox, to kill her. Dr. Cox eventually injects Ms. Boyes with a lethal dose of potassium chloride. So this pair of cases emerges in page 19 of Dunn and Hope. Now, here's the big question. Was it morally okay for the doctor to do what he does in case one? Second question, is it morally okay what the doctor did in case two? Now that you've tried to answer these questions for yourself, we might reflect on how we react to these cases. Most of the time, people will tell me that case one, there's nothing morally wrong with what happens in this case. They think basically that at end of life, a patient might decide to forego a painful surgery or uncomfortable chemotherapy on the basis of the idea that extending life isn't the only important thing to do. So I would say a vast majority of people will say that there's nothing morally wrong with what's done in case one. But if we go to case two, it gets controversial. There are some of us who might say that Dr. Cox does something wrong in this case, something wronger than what was done in case one. But others will say, actually, there's no moral difference between the cases. In fact, it was okay for the doctor to respect a refusal of treatment, and it's actually okay for a doctor to respect a patient's request to be killed. So that's really the contrast in the question. Is there a moral difference between the cases? If so, what explains it? And we might also say, if there is no moral difference, how can we sort of respond to the people who do think that there's something wrong in case two, where there's nothing wrong in case one? Before we jump ahead, we might talk about some important concepts connected to the topic of our discussion, euthanasia. So let's just get some definitions on the board. And these are the definitions that are being given to us by Dunn and Hope. Dunn and Hope are going to say that euthanasia, properly defined, is the practice of assisting in a patient's death where the assistance is motivated by the hope of benefiting the patient. So we might say that it is a practice of knowingly causing a person to die through medical means. That's the first point. And the second point is that it's doing so with a certain kind of motivation, right? We might use the very same drugs for both euthanasia and for the death penalty. It's not always the case that the same drugs would be used, but conceptually that's possible, right? But we would not say that the death penalty, or capital punishment, as it's sometimes referred to, is the same thing as euthanasia, because the motivation behind euthanasia in a medical context, such as in Lillian Boyce's case, is motivated by the hope of benefiting the patient, by relieving their suffering, whereas capital punishment is motivated by a desire to punish, right? So not all killings are euthanasia. Some people have equated what the Nazis did during the Holocaust as a practice of euthanasia, but that seems implausible, given that it did not seem as if Nazi killings of Jews and other people were motivated by a desire to benefit or relieve the suffering of these people, but rather it was motivated by hatred and a desire for these people to not exist. So within this realm, we could say that what the Nazis were doing was not euthanasia. Now, we can make some further conceptual distinctions, and your book will give you exact wordings on these different kinds of euthanasia, but I'll explain how these ones differ. So some euthanasia is voluntary euthanasia. Now, this is euthanasia where a patient will competently ask to be euthanized and then receive that treatment from their doctor. We can contrast this with non-voluntary euthanasia. This would be a situation where a patient is euthanized, but that patient is no longer competent or even able to consent to certain kinds of medical procedures. So for instance, we could imagine, at least, that a patient could be euthanized on the basis of what we call an advance directive. Basically, a directive that a person can sign, which will say, if I find myself in a certain state, what I would like you to do is to euthanize me at this point. So we're going to call that non-voluntary because the person is not directly asking for it at the moment of being euthanized. So this is where consent is being given through some sort of proxy, usually a person given power of attorney. So that contrasts with a person directly asking for the procedure. Well, this is somebody who's not asked for it, but who has been given proxy consent. That's non-voluntary euthanasia. And we could also consider involuntary euthanasia. So in the case of involuntary euthanasia, this is where a person is euthanized. So a doctor says, this person is suffering too much. It's going to benefit them to have them not be alive anymore. But the patient is saying, please keep me alive. So this is a case where, though the patient is making a certain request to not be euthanized, a doctor euthanizes them anyways. Now, here's something to notice. Everybody, pretty much everybody in their right mind, is morally against involuntary euthanasia. So nobody advocates for that, and nobody believes that should be made legal, right? But some people will be okay with non-voluntary euthanasia, and perhaps even more people will be okay with voluntary euthanasia. If we look back just a moment, the case of Ms. Boyce, assuming that she was competent, she was asking to be killed, and in that sense, right up until the moment of her death, she was consenting to being euthanized. So we would consider that a case of voluntary euthanasia. Now, we can contrast these forms of euthanasia with withholding treatment. So this used to be called passive euthanasia. So this is a situation where, and here's the technical definition from the book, X allows Y to die by withholding life-prolonging treatment. This might be because X believes that withholding treatment is for Y's benefit, or because Y refuses the treatment. So we can actually notice here that if we go back to our pair of cases, so this would be a case of withholding. I think I missed an H there, but this is withholding treatment, whereas this is voluntary euthanasia. Right, so we can already see that we've got some conceptual distinctions, right? So now we can start to ask the question in general. If you're having differential reactions to these two cases, you could ask the question, in other words, is withholding treatment morally more defensible than voluntary euthanasia? Now, we can also talk about withdrawing treatment. Now, this also used to be called passive euthanasia, and part of why we've sort of stopped using the term passive euthanasia within medical ethics is because it kind of blurs this distinction. So when we're withdrawing treatment, what's going on there? Well, it is X allows Y to die by withdrawing life-prolonging treatment. This might be because X believes that it's for Y's benefit, or because Y completely refuses continuation of treatment. So one case that we might consider here is if a patient is being kept alive, but only because they are on a ventilator. Now, if the doctors and if the patient or their proxies say they don't want to keep the patient on the ventilator anymore, the ventilator might be turned off and removed. And oftentimes when this happens to patients, they may well die after a certain amount of time. So this distinction between withdrawing and withholding, we might actually have some people who say, like, look, withholding treatment might be ethically defensible, but withdrawing treatment might be less so. That is, once a patient is relying on something to stay alive, they might be entitled to insist that they keep receiving that treatment. And we should also distinguish euthanasia, not from just withholding and withdrawing, but also from physician-assisted suicide. So when we're talking about medical professionals injecting a lethal drug in order to benefit a patient, that's what we're going to call euthanasia in this context. And we can contrast this at least with physician-assisted suicide. So if it's a medical professional administering a lethal dose to a patient, we're going to call that euthanasia. But when patients administer doses to themselves, and these doses might be prescribed by a doctor, but then the patient will get the prescription filled and put the pills in their mouth themselves and swallow those pills themselves, that's going to be considered physician-assisted suicide. Now, one thing that we can do by making these distinctions is understand that there are distinctions, and maybe some people might be okay with some of the practices that I've laid out here, but not other ones. And sometimes when we're talking about euthanasia, we might need to distinguish between voluntary, non-voluntary, and involuntary. We can also point out that when we have this distinction between euthanasia and physician-assisted suicide, we can realize that, for instance, Euthanasia is not legal anywhere in the United States, but physician-assisted suicide is legal in some parts of the U.S. Physician-assisted suicide is legal in 10 states as of this recording in January 2024. Most recently, Washington, D.C. Became a place where physician-assisted suicide is legal. It was also ruled in 2022 that Oregon, where physician-assisted suicide is legal, non-residents of Oregon can receive physician-assisted suicide there. There are also countries across the world where not only is physician-assisted suicide legal, but also active euthanasia. That is, a lethal dose that's being administered by doctors. So for instance, in Belgium, Luxembourg, Spain, New Zealand, as well as my home country of Canada, euthanasia is now legal. So the dose could be prescribed and administered by the doctor. And we might notice that there may be some cases where a patient is so ill, that is, they are so immobilized, that they would not be able to participate in physician-assisted suicide, though they may still be able to consent to euthanasia. All right, so we've got some distinctions on the table now. We've got euthanasia, withholding and withdrawing treatment, and physician-assisted suicide. And we noticed that in our case comparison, what Lillian Boyes received was euthanasia, seemingly voluntary euthanasia, whereas the 92-year-old man with prostate cancer was a case of withholding treatment. So Dunn and Hope, in our little textbook, are arguing in defense of euthanasia. So it is the case that Dr. Cox, the doctor who gave that lethal dose to Ms. Boyes, did receive jail time, and he did have his medical license suspended briefly. But Dunn and Hope are going to say it was a mistake. Ethically speaking, the law got it wrong, they think. So what they're going to do is they're going to offer their main reasons in favor of allowing euthanasia, and then they're going to respond to counter-arguments against the practice. This is a great way of thinking about practical issues in applied ethics. Try to give the main reasons why you think that something is the right thing to do, and then try to think of the best objections against that line of thought and give your responses to those objections. So, here are Dunn and Hope's reasons in favor of Dr. Cox's choice. This choice to administer active euthanasia to Ms. Boyes. So, first thing that they point out is that Dr. Cox was doing what was in Lillian's best interests. So their thought seemed to be that given the state of her very advanced rheumatoid arthritis and the way that it was contributing to other problems, if you read more on the case, you'll know that Ms. Boyes had very bad bed sores and stomach ulcers. We might think that her suffering was so great that her state of being was worse than how she would feel if she were dead. So we would say, in that sense, he was doing what was in her best interests. And two, autonomy. Lillian was making her own decision and was competent to make that decision. So we'll eventually see that this is capturing two main ideas in medical ethics. One is the principle of beneficence. We're doing what is good for the patient. And two, we're also respecting her autonomy. It is Ms. Boyes' choice to have her life intentionally ended early. So that's the first step, right? So they have offered their main reasons. They want to promote Ms. Boyd's well-being, and also that they want to respect her autonomy. And those are the reasons why they think that Dr. Cox should not have been made a criminal for what he did. So the second strategy is what we're going to do in the remainder of this video. So Dunn and Hope suggest that they could give 8 possible objections to Dr. Cox's choice. So what they're going to have to now do is say that all of these alleged reasons for being against euthanasia, they're going to argue that these reasons are not actually compelling ones. These are not good reasons to be against euthanasia. So let's run through these objections quickly. First one, attempting to kill the patient might cause more suffering than doing nothing. You may have heard stories about, for instance, botched attempts at lethal injection for prisoners on death row. Well, we might worry that there is a certain risk of causing suffering to the patient. That's the worry that comes out in objection 1. And 2, sometimes people argue that you have to make sure that a patient fights right up until the end because we might worry that there is a chance, even for very bad cases, that a patient could get better, even if they feel hopeless in the moment. 3, it objects that Dr. Cox will feel guilty if he follows Lillian's wish. 4 is a slippery slope argument. This will lead to mistakes about the patient's best interests or abuse of the system. 5, euthanasia should not be performed because it's illegal. 6, killing a patient interferes with nature, which is wrong. And 7, this is sometimes called like the argument from playing God. Killing is making a decision that should be left to God. It's only for God to decide about who lives and dies, not doctors. And 8, killing as opposed to letting die is a grave wrong. So we might say, look, in the case of Dr. Cox and Ms. Boyes, that's a case of killing, but in the case of the 92-year-old prostate cancer patient, that's simply letting die. And we might say that there is intrinsically an important moral difference between killing someone and letting them die. So those are the 8 objections that Dunn and Hope consider in their chapter. Now, the ones that are not bolded, that I say save for later about, the slippery slope argument, the interference with nature argument, and the God argument, we're going to set those arguments aside. In fact, we're going to talk about these arguments a little bit more when I give you a primer on critical thinking for medical ethics, which will be coming soon. But that leaves us with 5 other objections, 1, 2, 3, 5, and 8. So we sort of get a promise from Dunn and Hope that we'll talk about slippery slopes, nature, and God soon. But we can still do good philosophy, not by answering every single objection, but by getting clear on as many objections as we can, and then giving good answers to those objections. Right? Now, another thing that you might do if you think that there's an important moral difference between euthanasia and withholding of treatment, if you think that there is an important difference that's not captured in these 8 possible objections, well, that's an opportunity for you to do more philosophy. Explain what the real difference and the important difference between the 2 cases actually is. But Dunn and Hope are now going to proceed, and we'll consider what they say about each of these cases. So objections 1 and 2, we might cause more suffering than doing nothing, and there's a chance that the patient might recover from their illness. Well, here's how Dunn and Hope reply to these possible objections. They're going to say those things might happen, and we might sort of put a red underline against that word might, right? This is an objection about certain possibilities, right? And we're going to say we have to take the probabilities into account in an evidence-based way, right? So we would actually have to sit down and look at what research there is on what levels of suffering we might actually observe in patients when they are euthanized, right? And we'd have to look at the evidence to see how likely possibility one is. And we might also have to consider how likely it is that with certain conditions, whether it be end-stage rheumatoid arthritis or certain kinds of cancer, we might look at the question of how common actually is it for a patient to get better. They're also going to point out, if we're going to take into account the probability that a patient will get better, we should also take into account probabilities, and they're going to point out often high probabilities, that if we do nothing, if we do not fulfill the patient's request, there is a high chance that that patient is going to suffer. So if we have to consider the possibility of harming more by doing nothing, by attempting to kill the patient than doing nothing, we might also factor in the probability of causing more harm by doing nothing than by fulfilling their request. On 2, there's a chance that the patient might recover from the illness. We should also point out there's a chance that the patient might not recover from the illness. And if the patient is suffering, we'd have to factor in large amounts of suffering on the high probability that they're not going to get better. So they think that these possibilities raised by objections 1 and 2 are pretty remote in very many cases of euthanasia. So if there's a high probability of suffering if nothing is done, the stronger that probability is, the stronger the case in favor of euthanasia seems to be. All right, let's go to objections 3 and 5. 3 says Dr. Cox will feel guilty if he follows Lillian's wish. And 5 said euthanasia should not be performed because it's illegal. Well, here's how Dunn and Hope reply here. Objection 3, they say, is going to beg the question. When philosophers talk about begging the question, they're not talking about raising an interesting possibility. In fact, what they're saying when they're talking about begging the question is it's a problem with certain kinds of arguments. And arguments that beg the question are arguments that assume the conclusion that they're actually trying to prove. So the point that Dunn and Hope are replying with here is that on 3, it's assuming that it's wrong to fulfill Lillian's wish, or at least that Dr. Cox, if he was thinking about things correctly, would feel guilty. But if you're trying to give that as a reason for believing that euthanasia should not be legal or acceptable, it actually assumes the wrongness that the argument is trying to establish. We might notice if there were nothing wrong with what Dr. Cox is doing, it seems like the risk of guilt would be pretty low. We might also notice whether or not it's wrong. Maybe Dr. Cox has thought about this issue carefully, and in his case, he wouldn't feel guilt. So that's why Dunn and Hope think that objection 3 is not a very good argument. Objection 5. Now, it says that euthanasia should not be performed because it's illegal. The case of Dr. Cox took place in the United Kingdom in the 1990s, and it was and still is illegal to perform euthanasia in the United Kingdom. Now, it is true that there might be ethical problems with a doctor doing things that are illegal, but which they feel are morally right. For instance, here in America nowadays, there are many doctors who believe that it's morally okay to get an abortion, but at this point, they will not provide abortions to their patients. And part of what they might say is like, look, if I perform an abortion for one of my patients, I would likely lose my medical license and go to jail. Well, that would be a reason to not break the law for a doctor. But we should notice that the fact that it is currently illegal, for instance, to administer euthanasia in the United States, just like it's currently illegal to perform an abortion in many parts of the United States, these points don't really answer the deeper ethical, philosophical question about what should be legal, right? So the fact that it was illegal and Dr. Cox was given a short jail sentence and was suspended from practicing medicine for a certain amount of time, that answers the question about what the law says about him. But when we do ethics, we want to go one step further. We can ask the question, well, was it a good law? Right? So objection 3 and objection 5, these objections do not impress Dunn and Hope. Here's the last objection we'll consider. It's the objection that killing, as opposed to letting die, is a grave wrong. So there's something inherently wrong about the act of killing that is not inherently wrong with letting this prostate cancer patient stop trying to continue and lengthen his life. Here's how Dunn and Hope reply. The main reason why we think that killing is wrong in a civilized society is because there is a harm to the victim, right? If I were to be killed today, we might say like it would be a terrible thing. It would be a violation of my rights. Not to mention, it would miss me out on a number of positive experiences in my future, right? I wouldn't get to experience the joys of teaching more philosophy classes, spending time with my friends and family, listening to and playing music, petting dogs, eating pizza, all the stuff that makes life beautiful and worth living. So it's usually wrong to kill people because it harms you in all sorts of ways. But it seems harder to believe that Dr. Cox harmed Ms. Boyes. She was not enjoying life anymore at the advanced stage of her rheumatoid arthritis. So here's how Dunn and Hope put it at the end of their chapter. They say, it is perverse to seek a sense of moral purity when this is gained at the expense of the suffering of others. Now they end the chapter at page 26 by saying this. Do you think that this final sentence, or this sentence that we've got on the screen, is it a fair point, or is it unscrupulous rhetoric? Are they playing with the reader's emotions or trying to guilt people into agreeing with them? Well, that's a hard question, but we might notice that from their point of view, there is a problem with allowing a patient to suffer when the only reason that can be offered is a doctor saying, I want to have clean hands. I do not want to be a participant in this patient's death. So that is their response to 5 of these 8 objections listed. As we'll eventually see, they will have some things to say about slippery slope arguments, arguments from nature, and arguments about God. We'll take those questions up in a little while. But the next time I speak with you, we will look at Why Doctors Must Not Kill, an essay by the bioethicist Leon Kass, as well as Justifying Voluntary Euthanasia, which is an excerpt from a book written by the famous philosopher Peter Singer. So that's where we'll continue the discussion in a little while. In any case, thanks for listening this time, and in the meantime, be well.